Thank you for joining us today here in Washington, D.C. For folks on screen, thank you as well. And I cannot tell you how great it is to see people together to talk about how we transform the healthcare delivery system, and can't thank you enough for all your work that you do. I want to thank Alice and Mark for their leadership. I want to thank the CMS team for working tirelessly to change care, to improve care, and also want to thank everyone here that really has the same mission. I want to just talk about some thoughts, reflections for what we've seen throughout the country and some of the challenges that are really apparent to us and how we think we need to move forward given everything that we're currently facing. We have certainly faced hardship. We have faced trial during the past 3.5 years, and the healthcare system, to our analysis, is still bouncing back. So for CMS today, and this is my second time now at CMS, we are a much different organization. I think the first is just size and scope. We are covering now 1 in every 2 people in our country. And think about that. Most people during their lifetimes will be covered by a CMS program. They have a baby, they have a disability, they turn age 65. Chances are they will navigate CMS programs several times during their lifetime. The second change for CMS today, too, is that we have seen tremendous change for how we deliver healthcare benefits. That it used to be that fee-for-service payment systems was the primary way that we paid care. But instead today, CMS contracts with third-party managed care organizations. So we're covering more people, but through third-party managed care organizations. So if we want to change care, we want to change how we think about care, we have to realize 2 facts. One, that people will change programs rapidly. The populations that CMS covers change programs throughout the year. Some people change coverage every 12 months, 6 months, 5 months. So we have to think differently for how we promote more value-based care. And the second thing is that we have to do it differently. CMS, being a direct payer, will have less impact over time. CMS contracting through third-party organizations, managed care plans, that's how we're going to change care, which means that we need to think about different strategies. We need to think about not just paying for care directly, but really working together to have common values, common frameworks for how we think about care transformation. So those 2 changes for CMS will really drive work, really drive strategy for how we think about the future. I've had the chance now to travel to all CMS 10 regions. And so CMS operates 10 regional offices throughout the country. Can I set a goal for myself to travel to each one? And through those trips, we have seen really phenomenal work that is happening, but we've also seen hardship throughout the healthcare system. And 7 or 8 things stand out for me. First is Colorado. Colorado rural hospitals today no longer provide maternal care. People are having babies delivered, driving in the ambulance because their local rural hospital no longer provides maternal care. In Philadelphia, we saw Temple Hospital that had people coming out of the doorways because the other safety net hospital closed, which means now Temple takes on more and more patients. People couldn't get into the hospital that needed hospital care. In San Francisco, we saw healthcare workers working the streets, performing miracles to serve the homeless population. In Tampa, we talked to last week 4 ACOs that told us their hospitals still don't give them discharge information for their patients coming out of the hospital. So 10 years after we set the ACO regulations, hospitals today still don't communicate back to the ACOs to help coordinate care for their patients. In Puerto Rico, we saw people sitting outside hospital walls sitting in beds, trying to get into the hospital, trying to get into care, but the hospitals didn't have enough healthcare workers to serve those that needed care. In Alaska, we heard from very angry Medicare beneficiaries whose primary care practice closed suddenly, leaving more than 4,000 patients, Medicare patients, trying to find primary care. In Fairbanks, Alaska, we saw beautiful facilities, state-of-the-art, that were sitting empty because they didn't have enough healthcare workers in order to staff those facilities. And in Kansas City, we saw children living in the ERs for 30, 60 days, couldn't find behavioral health care, which meant they had to stay in the ER, which just made their condition even worse. So we are seeing throughout the country a phenomenally changed healthcare system that is stretched, that is challenged, that is struggling really to provide care. How many people in this room have tried to find a brand new primary care physician? Who's found one in the last 2 months, 6 months, 9 months? It is very, very difficult right now just to get access to core services. So this means to us, this means to CMS, that now is the time for us to think about healthcare delivery system transformation differently, not to earn shared savings, not to earn more revenues, but to think about how to solve the fundamental challenges that we're seeing throughout the healthcare system. Healthcare workers who are burdened, children that can't get access to behavioral health services, people who can't get their discharge data from the hospital back to their primary care physician. Those are the things that we now need to think about more than ever, given the challenges that we're seeing throughout the healthcare system. So 4 things that I think about when we think about healthcare system transformation that I think all of us should be thinking about to do this very hard work. First point that I think about is that those that suffered during the pandemic, those that suffered the most, were precisely the patients that value-based care really needs to take care of. Think of the dual-eligible population. Think about those who had ESRD. Those were the patients that had the highest mortalities, had the highest morbidities. Those are precisely the patients that are the best opportunities to think about value-based care. The second thing I think about, something that Liz Fowler and I saw traveling to Boston. So we polled physicians, said to them, what does value-based care mean to you? How many physicians do you think really had the same answer? 5, 10, 15? Suppose we were to poll 50 physicians and ask them, what does value-based care mean? How many answers will we get? We get 50, 60, 75, 100? That needs to change. If we were to poll primary care physicians, take 50, go back to that statement that we heard back in Tampa, how many physicians get the discharge instructions from their hospital to them, how many would say yes? 5 out of 50, 2 out of 50, 10 out of 50? Been doing this work far too long to have that answer not be 50 out of 50. The fourth thing I think about is, suppose we were to poll 50 beneficiaries, Medicare beneficiaries, and said, what does value-based care mean to you? Do you think their answers would be about risk and payment and the attribution models that we have to think about? They have different answers that we need to pay close attention to. So as we think about this very complicated work, and as we think about the work that we have ahead of us, and there is a very, very fragile healthcare system that we are facing, I think we need to think differently. We need to think about things much, much differently. So suppose that we were to say that rather than trying to code patients more aggressively, we thought about ways to truly stop progression of chronic care disease. What would value-based care look like if we changed that mentality from coding more aggressively to truly changing how we think about disease progression? What if we thought about differently the need to hoard information, the need to control information, but rather to share information. So 50 out of 50 primary care physicians could say strongly they get the discharge instructions when their patients go to the hospital. They know which patients go to the hospital that then they can take care of. Suppose that we were to think about differently a value-based care systems that were about health systems own business model, but instead thought about ways for us to collaborate more, share information, share methodologies, share the quality frameworks to take away burden from a healthcare system that can't afford to learn 4, 5, 6, 7, 8 different programs. Suppose that we were to think about a value-based concept where the need for short-term savings was changed to think about long-term transformation, not just focus on what's in it for me, what's in it for our healthcare system, how do I maximize profit in order to think about care transformation. And what if we were to think about value-based care differently, to truly listen to what patients tell us what they want from their healthcare system? They don't think about risk, they don't think about shared savings. They want more time with their doctors. They want the healthcare system to work when they need it. That's what patients tell us what they need from us. So what will CMS do? So I think the CMS Foundation, the CMS framework really has 4 elements. First is that we have to perfect the models that we operate. You have seen tremendous work from our team to really get the models right. To close those down don't seem to work, but for those that have promise, number 1 goal for us, make sure we get the methodology right. Second thing that we're doing is carefully releasing new models that respond to specific needs for our healthcare system, behavioral health, maternal health. Those are the challenges that we see for us going forward. The third is that we need to figure out better for how we scale value-based care. We need to think about the infrastructure better. We need to think about how we scale these systems in a way that's truly open source, not owned by any one payer. And to also make sure that our models can be extended to all payers over time. And fourth is that we need to work harder to truly integrate specialty care back to the primary care office, to really have it work collaboratively, to have it work well, to have it work seamless. That's what I think patients want. They want their healthcare system to talk to each other, not to hoard information, not to hoard the overall profit, but to bring that true connection, that true collaboration together. But these are simply the building blocks. They're not the end goals. The end goal really is changing how we think about delivery care transformation, changing how we think about the management systems. What if every CEO said throughout the country that each of my patients will get a warm handoff back into the community when he or she is discharged? Suppose that CEOs throughout the country for health systems, for health plans said we want to give more time back to physicians so they can spend more time with their patients. We're not going to build the workforce anytime soon, so we have to figure out ways that we can get patients out of the hospital faster, not lined in the halls, not coming out the doors. That is the core challenge that we have going forward. So the CMS team is working harder than ever before to make sure that we can see a much, much different healthcare system, but we need everyone's here help. We need everyone's focus to ensure that we build back healthcare systems, not just for us, but for the patients that we serve, the beneficiaries that we serve, and for all the caregivers throughout the country. So with that, you will have a fantastic conference. Thank you for coming. Thank you to our team and for all the work that they do every day. So with that, thank you.